So it gives me great pleasure tonight to introduce to you Dr. John Hurst. Dr. Hurst has graduated from the University of Edinburgh in 1997. That makes him quite young, but we're very happy to have him. He is a senior lecturer in respiratory medicine at UCL. UCL Respiratory Medicine at the Royal Free Home is the home of the London COPD cohort, and Dr. Hurst has a particular research interest in mechanism of exacerbation, susceptibility, and cardiovascular risk. He was awarded the 2012 European Respiratory Society COPD Research Prize. His clinical work focuses on the specialist COPD and bronchiectasis services, and he has an active role in undergraduate and postgraduate medical education. He is a previous associate editor at Thorax. During 2012, he was appointed to the editorial board of the American Journal of Respiratory and Critical Care Medicine. So without further ado, please help me welcome Dr. Hurst, who's going to talk to us about advances in COPD.
Thank you for the kind introduction, and good evening. So over the next 45 minutes or so, what I'd like to do is to talk about some advances in COPD, and in particular some learnings that I think we can take from the revised GOLD document. So I'd like to review the scope of GOLD, share with you some new thoughts on biology. The main part of what I'd like to talk about is predicting and reducing exacerbations, because I think they're important events in COPD. A few words about comorbidity, and then to end with a practical approach, an approach hopefully that you can take back to the clinic. So the GOLD committee was formed back in 1998, so Global Initiative for Obstructive Lung Disease. And by way of a bit of history to introduce this, their first strategy document was released in 2001. And there were then significant revisions both in 2006 and 2011. And more recently, there's been an update in 2013 too, which takes the search criteria looking for papers to include through to the end of December 2012. But most of what I'm going to say today, because it's based on the last major update, relates to the 2011 update, and the document's freely available on the web. So the scope of GOLD, well, it gives us some information about biology. That's not its prime purpose. What it is there to do is to help us with diagnosis and assessment of COPD. It helps us with some comments about the management, both of stable disease and of exacerbations, and it also has some words of wisdom to say about comorbidity. So let's start with the biology. This is the current definition of COPD according to the 2011 revision of the GOLD document. So it says, as you can read, that COPD is a common, preventable and treatable disease. It's characterized by persistent airflow limitation that's progressive and associated with inflammation in the lungs, and that exacerbations and comorbidities contribute to the overall severity. But it's worth just spending a few minutes taking that apart. So the first thing is that there's a common and preventable component to this. And you'll know from local data that the prevalence of COPD in the region perhaps somewhere around 5%. But there are big changes occurring in global population. This is a figure from The Economist, but the data comes from the World Health Organization. And this is a population pyramid. So we've got age on the y-axis, if you like, and global population with men on the left and women on the right. In 1950, that's the pale blue pyramid in the center. 2010, so roughly where we are now, through to 2050 and projections to 2100. And you can see that the maximum age, the maximum life expectancy is increasing. But that's not the main thing here. The major change that we're seeing is that this pyramid is developing shoulders. In other words, the proportion of elderly people compared to the total population is increasing. And that's important because COPD is predominantly a disease of the elderly. So if they're going to have more elderly people in the population, this is something we're going to be seeing more of as physicians. Also to point out that there's more women around than men. And there are important gender differences in COPD. Just as an example, women report exacerbations more frequently than men do. So there are some gender differences too. So we're sitting on a changing population demographic. The next part of the definition is that there's a comment about persistent airflow limitation. And what that means is to diagnose COPD, the only way to diagnose COPD reliably is to use spirometry. And the criteria that Gold suggests we use is a post-bronchodilator, forced expiratory volume in 1 second to forced vital capacity ratio of less than 0.7. Those are the diagnostic criteria according to Gold. However, we also know that there's a lot of underdiagnosis out there, wherever we're working in the world. That's true in the UK too. And therefore, it's important perhaps to think about how we can identify these missing people, how we can target them. So we could think about patients who have symptoms. It's not normal to have breathlessness if you smoke. That should trigger a thought process that says, does this patient have COPD? It's not normal to have cough and sputum. You might also think about exposures. So in patients who have significant exposures to tobacco smoke, be it through cigarettes or water pipe, in other parts of the world, biomass fuel, risk factors like low birth weight, prematurity, or genetics, the best example of which would be alpha-1 antitrypsin deficiency. If we're going to find these people who are undiagnosed, then these are the sorts of things that we should be thinking about. Because if we think about these things, we can perform diagnostic spirometry and not only make the diagnosis, but make the diagnosis early. An early diagnosis means that we can remove some of those exposures. We can encourage patients with smoking cessation. And perhaps early therapy is something that might be of value too. We now know that therapies that work in more severe disease are also active in milder disease too. So there is benefit in making the diagnosis earlier. One way to screen patients, if you like, or to screen people who might have COPD would be to use a tool such as this, the COPD assessment test, or CAT, and it's freely available online again, and as you can see, it's available in many languages, including here, Arabic. And the CAT is really designed to assess the impact of symptoms in COPD, but it might also assist in case finding, and I'm sure you'll be familiar with some data from the local breathe studies that suggest that that's true. We'll come back to the CAT a bit later. The definition then moves on to talk about inflammation, about a chronic inflammatory response to noxious particles or gases. Of course, it's normal to have inflammation in your lungs if you smoke, but the inflammation in people who get COPD is different, either qualitatively or quantitatively. And because of important work by Jim Hogg, for example, 10 years ago now, and others, we know a lot about the nature of this inflammation. We know that as the COPD gets more severe, more inflammatory cells are seen in the airway, and as we reach Gold 3 and 4 disease, interesting things start to happen, including germinal follicles, labelled GC there, which suggests that there might be an autoimmune component to this. But this is an inflammatory disease, and therefore anti-inflammatory treatment might be worthwhile. Here's how we think of things then just now. A patient needs to have a risk factor. It might be genetic. It might be recurrent infections, it might be low birth weight, and an exposure, typically cigarette smoke. And if you have the wrong set of genes with the wrong exposure, then the result can be COPD. The definition also says something about natural history. It says that this airflow limitation is usually progressive. And this brings me on to this famous figure from Fletcher and Pito back in 1977. What we have here is lung function on the y-axis and age on the x-axis. And the classic view has been that everybody reaches their maximum lung function about the age of 25, and then even in normal people, that's the green line, lung function declines with age. But if you are a smoker and you are susceptible to the effects of that cigarette smoke, in other words, you have COPD, that's the red line, you lose lung function at a more rapid rate. There's a big problem with this diagram, though. So I've had to change it. I've had to add this dotted line to the left. And that's because in the UK, if you start smoking, you don't start smoking at the age of 25. And I'm sure that's true here too. We start smoking if we're going to start smoking at the age of 12, 13, 14. So not only is smoke causing an accelerated lung function decline, smoking is affecting the developing lung so that you never reach your peak lung capacity. So there's a sort of double whammy there, which the original version of that graph ignores. Actually, we're having to revisit the whole concept of lung function decline, in part because of data that's come out of large observational studies like ECLIPSE. And I'm going to return to ECLIPSE a little bit later on too, but essentially this was an observational study of over 2,000 patients over 3 years. And this figure on the right looks at their lung function decline. We have the rate of lung function decline in mils per year on the x-axis, and the proportion of patients with that result on the y-axis. And if we go back to our original model, the idea that perhaps patients with COPD lose lung function twice as rapidly as normal controls, so perhaps about 40, 50 mils per year, actually in the ECLIPSE data set, only 38% of these COPD patients were losing lung function that rapidly. So we're having to reassess what we understand about the disease, because it's clear from this study that not all patients are declining lung function as rapidly, perhaps, as we initially thought. This brings me on to something that I think we're going to be hearing more about over the next few years, and that's the distinction between something that you could call disease severity. In other words, you could measure someone's FEV1 today and say, how bad is it, compared to something that you could call disease activity, if you like, the speed of a disease, how aggressive it is. And to assess speed or how active a disease is, you can't take a one-off cross-sectional view. So doing one-off spirometry, yes, that's how we make the diagnosis. But in terms of monitoring disease and identifying patients who are on a fast track to a poor outcome, then we need to do repeat spirometry so that we can see the rate of lung function decline. Alternatively, CT would be another way of doing things too, and perhaps in the future we might have ways of assessing inflammation. But for now, it's spirometry and serial spirometry that we need to use. This concept of severity and activity has been built on by Alvaro Augusti and colleagues who published this opinion piece in Thorax just last year, and they added in an aspect of impact as well. In other words, how much effect the COPD is having on somebody's quality of life. So we have severity components, activity components, and impact components. What I'm trying to persuade you of, in fact, is that this is a very complicated area. And if we just think about severity and activity and impact, and just classify those as low or high, already we have 8 different potential patient groups. COPD is a very heterogeneous condition, which means that we need to tailor therapy individually. This complexity is also now borne out in the GOLD definition. So the GOLD definition now explicitly talks about both exacerbations and comorbidities. And I want to come back to both of those two things a little bit later on. For now, though, let's look at complexity in a little bit more detail. This is a famous figure, and we have lung function here on the x-axis, FEV1 % predicted. And of course, the lower, the worse your lung function, the further to the left you are on the curve. And on the y-axis is health status, quality of life, here assessed by the SGRQ score, although you could use CAT just as well to perform in a similar way. And you can see it's generally true from this line that as your COPD gets more severe, as your lung function drops, the impact tends to get higher, so the SGRQ tends to get higher. But there's great variation here. So look at the patient that I've circled in red. The patient in red has an FEV1 of something like 80%. And yet they have a profound impact on their health status. And compare that to the patient in green. The patient in green has an FEV1 somewhere around 30%. But the impact of that FEV1, of that impairment, on their quality of life is much less. So this is a very, very complicated relationship. And it's suggesting that there are different groups of patients. The idea that there are different groups of patients in COPD, of course, is nothing new. We could go back to the 50s and 60s and talk about an emphysematous phenotype, a pink puffer, we would used to call them perhaps, or someone who had a more chronic bronchitic phenotype, a blue bloater. So these are not new ideas, but what we are doing now is we're calling this phenotyping, this complexity, this diverse group of patients, grouping them together into groups that we can call phenotypes. So the definition of a phenotype is an observable trait that results from genes or environment or gene-environment interaction. But as applied to COPD, it means something that we can measure today, something that we can observe, that's either going to predict a treatment that's going to work or an outcome. That's what we mean when we're talking about phenotypes. And there are many phenotypes in COPD. Chronic bronchitis, emphysema, FEV1, perhaps inflammatory phenotypes. I'm going to try and persuade you later that frequent exacerbators, that's a phenotype. So there are lots of different phenotypes, lots of different ways of looking at patients. What this means then is that the previous classification system proposed by Gold, so I'm now not talking about the 2011 document, but the 2006 document, the previous Gold classification, whilst it was useful, ignored all this complexity. So it was based on FEV1 and FEV1 alone. And it said if your FEV1's above 80, you're Gold 1, 50 to 80, Gold 2, 30 to 50, Gold 3, less than 30, Gold 4. But it ignored exacerbations, it ignored symptoms, it ignored comorbidities, and therefore it lost something about the complexity of patients. And this then is the biggest change for the 2011 revision, because the 2011 revision document suggests that we should classify COPD in a different way, that we should use a multi-component analysis. And it looks something like this. We now have a 4-quadrant model. And the first thing we should do, on the bottom, is that we should assess patients' symptoms. And we could do that either using the MRC breathlessness questionnaire, or here's our old friend the cat. And using that, we can say patients with less or fewer symptoms, we're going to call those Group A or Group C. And patients with higher or greater symptoms, we're going to call those Group B or Group D. Then, to make the distinction between these, we look at something that we could call risk of bad outcomes in the future. So one way to assess risk would be to look at the FEV1 as assessed by the old Gold stage. So if you're someone with low symptoms, you've been put into Gold A or C so far, and you're Gold 2, then you'd be in A. Whereas if you were Gold 4, you'd be up in C. The Gold Committee, though, suggests that we should assess risk in a different way as well, and that we should also look at exacerbations. And if you have 2 or more treated exacerbations per year, you should be considered high risk. Whereas if you have 1 or 0, you should be considered lower risk. And if those 2 risks disagree, you should go with the higher risk. So as an example, if we have someone with a CAT score that's more than 10, that puts them in B or D, and their Gold stage is 2, you think they might be B, but they're having frequent exacerbations, and it's D, then D trumps B, and they stay in D. So you go with the highest risk that the patient can be allocated to. So putting all that together, that gives us 4 different groups. Group A, you could call them lower risk, and they have fewer symptoms. Group B, they have lower risk, but they have more symptoms. Group C, well, they have higher risk and fewer symptoms, and there aren't too many patients in that group. That group is the smallest. And Group D, higher risk and more symptoms. So it enables us to classify patients perhaps in a more comprehensive way. The Gold Committee didn't stop there, though. The Gold Committee went one step forward and suggested what first line, which is here, and also alternative therapies might look like for each of those Gold 4 quadrants. So, for low-risk, fewer-symptom Gold A patients, the committee are suggesting that we might just want to use a PRN short-acting bronchodilator. For patients in Group B, who are still low risk but have more symptoms, perhaps first-line therapy there should be a long-acting bronchodilator. If you are higher risk, even if you have fewer symptoms, if you're higher risk, then first-line therapy should either be combination ICS-LABA or a LAMA. And if you're high risk with more symptoms, that's Gold D, then you may well need triple therapy. At least one or other of those 2 things. So that's what Gold is saying to us, and that's new for the 2011 revision. I'm not sure I completely agree with this. And the reason I don't completely agree with this is that trials have not recruited patients using these criteria. Trials recruited patients using the old criteria. So this remains to be seen how this is going to pan out. But what has happened over the last 5, 10 years in COPD is that COPD trials have really come of age. For the first time, we've got large studies in COPD with important clinically meaningful endpoints. So here are some examples. TORCH, a 3-year study, over 6,000 patients, salmeterol, fluticasone, and its individual components and placebo, powered against mortality. A huge study. Another huge study, UPLIFT, 4 years, nearly 6,000 patients, Tiotropium versus placebo added onto existing therapy, powered against FEV1 decline. Huge studies that have transformed our knowledge about the use of inhaled medication in patients with COPD. Let's just look at the TORCH study. So after a run-in, patients were randomized to salmeterol fluticasone on its own, salmeterol on its own, or placebo, and followed for 3 years. And there are over 1,500 patients in each arm of this study. The primary outcome, I've already said, is mortality, and that's the figure on the left here. This is a reverse Kaplan-Meier plot, so probability of death going from 0 upwards over the 3-year study period. The bottom line here is the combination ICS LABA, and although that had the lowest overall mortality, that did not reach conventional statistical significance. But when you look at exacerbations, then both salmeterol and fluticasone, and especially the combination of two, significantly reduced exacerbations. The UPLIFT study showed that tiotropium also effectively reduces exacerbations, which led on to INSPIRE, which asked the important question, is there a difference in exacerbation frequency reduction between salmeterol fluticasone and tiotropium? And the answer is no. They're equally effective drugs. The really interesting thing, actually, is if you have exacerbations during this study, the way that the exacerbations looked were different, depending on which arm you were. So if you've been randomized to salmeterol fluticasone, more of your exacerbations tended to need antibiotics. Whereas if you were randomized to tiotropium, more tended to need steroids, suggesting that exacerbations aren't all the same either. So we've moved away from the idea that COPD patients are all the same. I think probably we should be moving away from exacerbations all being the same. There are differences there, and this study provides the first evidence that that's true. Just a word about macrolides, because they're topical. This was published in the New England Journal less than 2 years ago. It's a multi-center US study using the macrolide antibiotic azithromycin, not to treat infections, but to prevent exacerbations. And the endpoint was time to the first exacerbation, which I've illustrated from the paper on this Kaplan-Meier survival analysis here. Top line is azithromycin, and the bottom line is placebo. And the bottom line is that there was a 27% reduction in exacerbations on people taking azithromycin. That doesn't come at no cost, of course, cost of the drug, obviously, but also increased macrolide resistance and the suggestion of hearing impairment. But it does, for the first time, suggest a new approach to exacerbation reduction. So, in 2013, we have a whole range of therapies which can reduce exacerbations in COPD. And that's important because I'm going to show you why exacerbations are important in just a moment. I can't go any further without mentioning these two things, because these two things, non-pharmacological management, are the most important management for me of patients with COPD. Smoking cessation, the only thing that's been shown definitively to impact mortality, and exercise and education classes called pulmonary rehabilitation. We absolutely need to remember these two things too. Okay, so that's enough about the biology. What I want to talk about next, for the next few minutes, is about exacerbations of COPD, which is a particular clinical and research interest of mine. As well as defining COPD, the 2011 revision also defined an exacerbation. And the Gold Committee defined an exacerbation as an acute event, something which happens suddenly, characterized by a worsening of patients' symptoms. And that worsening has to be beyond the day-to-day variation that patients with COPD often experience. It has to be more than that. And it usually leads to a change in therapy, steroids and antibiotics, for example. So that's how the Gold Committee defined an exacerbation. If you look at a group of patients who experience frequent exacerbations, and by that I mean 2 or more treated exacerbations per year, then they have bad outcomes. And this slide just summarizes a lot of data which looks at that. In the top left here, we have health status, as assessed by SGRQ. Patients who are frequent exacerbators have poorer health status than patients who are infrequent exacerbators. And that difference in health status is 15 units on the SGRQ score. And that's a score where a 4-unit difference is considered clinically significant. So these are huge differences. Bottom left, we have a study looking at lung function decline in patients who are frequent and infrequent exacerbators. And again, a statistically significant difference. The more exacerbations you have, the faster you lose your lung function. Not a big effect, but it's there. And if you want a really hard outcome measure, then you could look at mortality. So this is data from Spanish men, published by Sola Catalunya Thorax a while ago now, divided into patients with no exacerbations at the top and 3 or more by the time you get to the bottom, over a 5-year study. And in this study, if you were having 3 or more hospitalized exacerbations, your 5-year survival was not much more than 20%. And that's a terrible figure. That's a figure similar to many cancers, which means that we really need to take exacerbations seriously. And of course, they cost a lot of money to society, to the individual, and to healthcare services. So these are really important events. What would be really useful would be identifying when exacerbations are going to occur, if you like, high-risk time periods, but also who is going to get an exacerbation, high-risk patients. And that's what I want to talk about next, because there's some new data that suggests that we might be able to do that. And this also comes from the GSK ECLIPSE study, which I was fortunate enough to be involved with. And we published this paper in the New England Journal a few years ago now. Essentially what happened in ECLIPSE, it was an observational study funded by GSK. About 2,000 patients were recruited, and at recruitment, very comprehensive phenotyping was performed. Questionnaires, lung function, CT, biomarkers, all sorts of things. A huge amount of data was collected. And then the patients were monitored over a 3-year period, and many of those assessments were repeated. But for the sake of what I'm talking about today, the important thing is that their exacerbations were carefully documented and recorded, so that we knew how many exacerbations each patient was experiencing. And that enabled us to do 2 key analyses. The first analysis is to say, what can I measure in my patient today that is going to predict how many exacerbations they're going to have over the coming year? That's a clinically useful question, I think. And the second analysis is, how stable is that exacerbation phenotype over time? In other words, if I have a patient who's having frequent exacerbations in 2013, are they also going to have frequent exacerbations in 2014 and 15 and 16? Or is this a random thing? Is this variable? So another important question. So looking at the patient characteristics, you can see that there are over 2,000 patients in 46 sites, 12 countries. It was a global study. And I just want to make the point that most patients in the study were on effective treatment to reduce exacerbations already. So many patients were on tiotropium, many patients were on combined ICS-LABA. So this is what happens when patients are already on effective treatment. This is the first results slide. And what we're looking at in the orange-coloured bars are the proportion, the percentage of patients who were frequent exacerbators. And by that, again, I mean 2 or more treated exacerbations per year. And you can see, as your COPD gets worse, as you go from GOLD 2 to GOLD 3 to GOLD 4, the proportion of patients who are frequent exacerbators increases, such that in GOLD 4, about half the patients are. But just look what's happening in GOLD 2. So these are patients that we would consider to have moderate disease. Their FEV1 is between 50 and 80% predicted, but nearly a quarter of them are frequent exacerbators. So that might be the group where it's particularly important to reduce exacerbations so that they don't move from 2 to 3 to 4. So targeting frequent exacerbators in mild to moderate disease, I think, really is important. What about predictors of exacerbation frequency? Well, the best predictor of how many exacerbations you're going to have this year is how many exacerbations you had last year. And the good news about that is it means that we can identify patients in the clinic by asking a really simple clinical question. How many courses of antibiotics or steroids did you have for your chest in the last year? And if the answer is 2 or more, these are the patients we should be targeting for exacerbation reduction interventions, the whole range of things that we have available. And this effect was 4 times bigger than any of the other effects in any univariate analysis, and in a multivariate analysis too. Still, the best predictor of exacerbations in the future is exacerbations in the past. One more interesting thing came out on here was that the presence of gastroesophageal reflux disease also was associated with exacerbation frequency. And there's a huge literature about GORD in many respiratory diseases, interstitial lung disease, post-lung transplant, asthma. But really the literature in COPD and gastroesophageal reflux is just coming through. And there are lots of reasons why patients with COPD might get more reflux. But what we don't know, at least at the moment, is whether reducing their reflux reduces the exacerbation frequency. That's a question that we're trying to answer at the moment and is a question for the future. Okay, what about the stability of the phenotype? How likely are you to remain in the same group? This is a slightly complicated figure, so take things slowly. What we're looking at here is the first year of the study, and I divided patients into the people who had no exacerbations in year one, that's the top bar in white, one exacerbation in year one, that's the middle bar in beige, and at the bottom, 2 or more exacerbations in year one, that's the orangey bar. Let's just look at the orange bar. So let's just ask the question, if you had 2 or more exacerbations in year one, what happened in year 2? Well, there were about 20% of people or so who had frequent exacerbations in year 1, but of that group, about 60% of them will continue to have frequent exacerbations in year 2. And if we take that group forward to year 3, in other words, if you were a frequent exacerbator in 2011 and in 2012, there's about a 70% chance that you'll also be a frequent exacerbator in 2013, suggesting there is some stability to the phenotype. Actually, the same's true if you look for patients who don't have any exacerbations. There were rather more of them in year 1, about 40%. Take them through to year 2, about 60%. And if you had no exacerbations in 2011 and no exacerbations in 2012, there's about a 75% chance that you won't have any exacerbations in 2013 either. So the phenotype is relatively stable, at least at the extremes. Of course, I'm now going to complicate things by putting all the missing data in the middle. So that if you just had one exacerbation in year 1, well, there was about an even chance in year 2 of having 0, 1 or 2 or more. So there are some patients who have a more variable course in the middle. Why might that be? Well, I think that you can be inherently susceptible to exacerbations, either because of your genes or your COPD or whatever it is. You can be inherently susceptible to an exacerbation, but you don't actually get an exacerbation unless you meet a sufficient trigger. And that's usually a respiratory virus, bacteria, pollution. So if you like, an exacerbation is the end result of 2 things. An exacerbation is what happens when you have a susceptible patient who meets a sufficient trigger. And we're just starting to understand what it is that affects susceptibility and what it is that affects the sufficiency of the trigger. More ongoing work within COPD. So that's high-risk patients. We can identify patients at risk by asking a simple clinical question. What about high-risk time periods? These are hospital admissions in London for COPD exacerbations. The data is quite old now, 1999 through 2005, but things haven't changed at all. And what I really want you to take away from this graph is that this graph is not a flat line. There are peaks and troughs, and those peaks and troughs in London are occurring in October, and they're occurring in January. They're occurring about the time that respiratory viruses are circulating maximally within the community. So exacerbations certainly aren't random, that's the first thing to say. There's definitely a seasonal component to these events. But there's something else happening too, and here's 2 pieces of background information. This is an audit by the British Thoracic Society looking at what happened to patients after they'd been admitted to hospital with an exacerbation of COPD. And about 1/3 of them would end up readmitted to hospital with a second exacerbation within 3 months, suggesting that once you've had an exacerbation, you just might be at risk of having another one. A very different study design, this is from Sean Aaron in Canada. This is a randomized controlled trial of prednisolone for outpatient treatment of COPD, published in the New England Journal in 2003. And this is a Kaplan-Meier survival plot. And this is not overall survival, this is survival without needing another course of steroids or survival without needing another hospital visit. And what Sean Aaron showed is that actually, even if you are on active treatment, even if you're on prednisolone, then over the course of that study, perhaps somewhere around 1/4 to 1/3 of patients were needing yet another hospital visit for yet another course of steroids. So there's 2 very different pieces of information, both of which suggest that after you've had one exacerbation, you might be at greater risk of having another one. So we wanted to look at that with some data that we have access to in London. But before I show you that, I just want to make a distinction between something that you could call exacerbation relapse, that's over here on the left in the red, and exacerbation recurrence. Relapse, for me, is as your symptoms get better, maybe there's a blip and they get temporarily worse before they completely get better. Whereas actually what I'm interested in here is the green. The idea that you can have an exacerbation, it can completely get better, but then another one happens quickly. So the question is whether exacerbation recurrence is a true phenomenon or not. And we looked at that in a paper published in the Blue Journal back in 2009, where we compared the expected number of exacerbations and the timing of those in our patient cohort in London compared to the actual number. And the data suggested that, in fact, if you have a patient today with an exacerbation of COPD that's treated and get better, about a quarter of those patients will have a second, completely separate event within the next 8 weeks. And that's much higher than you'd expect, about 20% higher than expected. So I think this concept that exacerbations are not random in time, that if you have one, you're more likely to have another sooner rather than later, is real. The reason that's important is when we come to think about therapeutic paradigms. How do we deliver exacerbation reduction strategies? Well, this is what we do with high-risk patients. Some interventions we have, and perhaps influenza vaccination would be the best example. Some interventions we give once, and there's a durable protection from exacerbation. But most of the things that we have, including most of the pharmacotherapy, of course, is like 2. You have to keep taking the drug to retain the benefit. If you stop taking the drug, you're likely to have another exacerbation. You have to stay on it. But if this concept that exacerbation clustering, that they stick together in time, is true, that raises the question that there might be a new way to prevent exacerbations. Because if you can work out when they're going to occur before they happen, then perhaps you can leap in with therapy to stop it. And that's a hypothesis that we're testing in London just now. The question is how you identify patients. And actually there's some data to suggest that systemic inflammation might be one way of doing that. So here's some data that plots CRP on the y-axis. It's a log scale. And time to next exacerbation on the x-axis. This CRP wasn't measured at baseline or exacerbation onset. This was a CRP measured after the exacerbation had recovered. And the higher your CRP after an exacerbation has recovered, the sooner your next exacerbation is likely to be. So perhaps in the future we might have a way of identifying patients. So, final comments really relate to comorbidity. Here's a definition of comorbidity. Comorbidity is the idea that if you have one disease, you often have other diseases with it. And COPD being a disease of smoking people who are often elderly, of course it's quite obvious that many of them don't just have COPD, that they have other things too. What other things and how common they are has been a subject for debate, but has recently been looked at in this paper from the Blue Journal, describing something called the comorbidome. And it's a complex figure, but I think it's quite helpful. What they've done here, what the authors have done, is group different comorbidities by organ system using colours. So all the cardiovascular comorbidities, they're all coloured in red on this diagram. The next thing then is the size of the circle. The size of the circle represents what proportion of patients with COPD have that particular comorbidity, and that's what a 50% circle looks like. So you can see that about 50% of people have hyperlipidemia and hypertension. And then the third thing the diagram does is look at the association with mortality. The closer you are to the centre of the circle, the more tightly that comorbidity is associated with mortality. And if it's statistically significantly associated with mortality, then it appears within the black dotted line. And clearly coronary artery disease is on that list. COPD can affect your comorbidity, but the reverse is true too. Comorbidity can affect the COPD, so we have a vicious circle. And to show you some data from that, this is an astoundingly large US study, a database analysis, of course, but which looked at 47 million hospital discharges for a whole variety of conditions, including coronary artery disease, heart failure, pneumonia, all sorts of things. It's projecting quite small, I think, isn't it? But the black bars are the patients with COPD and the open bars are the patients without. And for each of those conditions, For any one of those hospital discharges, if you had COPD, your mortality was clinically and significantly higher. So that means that we need to educate our colleagues, our cardiology colleagues, for example, about the importance of COPD in their coronary artery disease patients. The reverse is true too. So comorbidities affect COPD. This is analysis from a UK primary care database looking at the incidence of myocardial infarction on the left and stroke in the right in patients with COPD, that's the top line on both graphs, and without COPD, that's the bottom line on both graphs. So if you take a patient with COPD, even compared to a matched smoker, so someone who smoked a similar number of pack years, the patient with COPD has a greater vascular risk. And this isn't just non-fatal MI, non-fatal stroke. This is death too. I've already mentioned the TORCH study, and one of the reasons the TORCH study was so important was it was powered on mortality, which means that the mortality data had to be collected and verified in a very careful way. And so this is the mortality data, and there are about 900 patients died during the course of the TORCH study. And you can see that only about 1/3 of patients with COPD in this study died because of their COPD. 2/3 didn't. Of the 2/3 who didn't die because of their COPD, about half of them died from cardiovascular disease, myocardial infarction, stroke, and sudden cardiac death. And the remaining half died from cancer. And it won't surprise you to learn that it was predominantly lung cancer in this group of patients who smoked. What this means then is that you can be the best COPD doctor in the world. You can absolutely treat someone's COPD perfectly. But if you're not thinking about their cardiovascular risk, and if you're not alert to changes in clinical status that might suggest lung cancer, you're not able to improve mortality in the best way, I think. So to end, a practical clinical approach. This is what the GOLD document says, to bring it back to GOLD, about our aims for assessment in COPD. It says that we should make the diagnosis, make the correct diagnosis, of course. It then says that we should assess the current level of patient symptoms, and we could use a CAT, for example, to do that. We should assess the severity of the spirometric abnormality, and we should assess the frequency of exacerbations by asking the question, and we should look for the presence of comorbidities. This is important because of what we're trying to do. The goal of therapy in COPD, in a very simplistic way, is to reduce mortality and to reduce morbidity. Reducing mortality, we need to think about smoking cessation. And for patients in respiratory failure, then oxygen is relevant too. But for reducing morbidity, we've got a whole range of pharmacological and non-pharmacological interventions which can improve symptoms, health status, functional capacity, and reduce exacerbations. You can identify the frequent exacerbator very simply. This is free. You just have to ask the patient the question. How many courses of antibiotics or steroids did you need over the last year for your chest? And if it's 2 or more, those are the patients to target for all the interventions that we have to reduce exacerbations. And in terms of comorbidities, it's about measuring people's blood pressure. It's about assessing their cholesterol. It's about looking for osteoporosis. It's about screening for depression. And it's about managing those things according to local and national guidelines. So, to summarize, I think that the updated GOLD document really is a useful resource for COPD management. And perhaps the biggest change over the previous version is this idea of combined risk assessment, this ABCD business, and using that to guide therapy. It emphasizes that we should make the diagnosis securely, which needs spirometry, and that we should make the diagnosis early, because if we can make the diagnosis early, we can intervene and perhaps stop patients in the future from getting so severe. The latest definition also highlights the role of exacerbations and comorbidities, and that's important because that's also something that we should be intervening on. And both in terms of case finding and assessing the impact of disease, we have new tools available, simple tools like CAT, which can help us. What is this all about? This is about reducing patient symptoms. It's about making sure that patients have fewer exacerbations. It's about increasing patients' functional capacity. And it's about giving people a longer life expectancy. That's why we all do what we do. It's about better patient care, resulting in better patient outcomes. I'd really like to thank GSK for the invitation to speak to you today, you for your attention. Thank you. Merci, shukran.
Thank you, Dr. Hurst, for an excellent presentation. We really loved the data you had on exacerbation. So with this, I'd like to open the floor for discussion and ask you the first question. There's very good data that shows that exacerbations, frequent exacerbators, end up dying more often. Why is it that decreasing exacerbations did not decrease mortality?
I think it does. I just don't think that we've had a study which has been sufficiently powered to show that. There are lots of reasons why we should be reducing exacerbations, and there's lots of data to support that in terms of quality of life, lung function decline. But yes, I'm sure that a treatment that reduces exacerbations is likely to reduce mortality. It's just that we haven't got that p-value, at least not yet.
Other questions from the floor? Dr. Georges Dabar, and then Dr. Jevelikian.
Thank you. Thank you for the excellent talk. Just to mention that in the uplift, the exacerbators, the one that were on the arm of the combo, required antibiotics, and the one who were on the tiotropium required steroids. Is it a signal regarding the next exacerbation for those frequent exacerbator being more according to whatever medicine they are on? We don't have too many medicine to use. We just have a couple of medicine to use in COPD.
So that data comes from the INSPIRE study, and it was a really unexpected outcome from that study. The idea that depending on what preventer you take results in a different phenotype of exacerbations, because what's been happening up until now, and still is to a certain degree, is that we just treat exacerbations all the same. We just give everybody increased short-acting bronchodilators, antibiotics and steroids. What this is suggesting is that exacerbations aren't all the same, and we need to be thinking in different ways about it. What I don't know, actually, is the answer to your question. I don't know whether the phenotype of exacerbation number 1 affects the timing of the phenotype of exacerbation number 2. What we do know, and Chris Breitling in Leicester in the UK has shown some data, is that if you have one sort of exacerbation, so say you have exacerbations which are associated with sputum purulence, then you tend to have that kind of exacerbation again and again and again. Whereas if you have wheezy, breathless exacerbations, you tend to have that sort of exacerbation. So there seems to be a sort of stability of that phenotype too. But there's so much work we still need to do in terms of unpicking different types of exacerbations.
So far, no separation. You treat infection and steroids and...
Well, I think in terms of clinical practice, people would feel comfortable using antibiotics when there's been a change in the quality of the sputum. That would be based on Nick Anthonison's data from '87. So more sputum purulence antibiotics you would use. Whereas if there's been breathlessness, particularly if it's been wheezy, then you might think about a short course of oral corticosteroids. That would be my personal practice in London.
Okay, thank you.
Dr. Jevelikian, to the back.
Yeah, thank you, Professor, for a wonderful presentation. I guess I had a similar comment to Dr. Dabar regarding the what maybe our intervention is altering in terms of the substrate for the exacerbations. For example, there are a lot of data coming out from TORCH and other studies that confirm that the use of inhaled corticosteroids conferred and increased in the risk of pneumonias. And I don't know whether this is something that's maybe affecting the colonizers or whatever, and maybe a correlate of what we saw in INSPIRE in terms of people on non-steroidal treatments required maybe steroids when they had an exacerbation, whereas those that had steroids ended up with antibiotics. But I wanted your comment on the study that was done in the VA, and that showed that having a global, combined maybe, and stepwise approach to a treatment of COPD ended up with a worse outcome. This was, if I'm not mistaken, it was Bourbeau, one of the leading investigators, and it was a big study from the VA hospitals. Any idea why that aggressive, multifaceted approach would end up in a worse outcome?
It's not fair, is it? You try and do your best for a patient, and you work as hard as possible, and it doesn't seem to work out. Well, I mean, you know, any intervention that you choose, be it pharmacological, non-pharmacological, is a balance of risks and benefits. And what we're just starting to understand, I think, is the interaction between some medications and comorbidities. So, you know, something might be appropriate for treating COPD, but whether it's appropriate for treating COPD with cardiovascular comorbidity, we don't know. Fortunately, of course, there are even larger studies ongoing. So Summit, for example, 6,000 patients, I think, perhaps even more. I think it's more. LABA, ICS, in patients at risk of cardiovascular disease or have that disease, looking at mortality. So some of this, I think, will start to become more apparent with more data. But you're right. I guess the important thing is to take an individual approach, always to take an individual approach.
We had one more question to the front, and that would be the last one.
I really thank you very much for that lecture. And you said that the exacerbations who were admitted were readmitted after 3 months. And eventually we came to the Indian experiment or trial that macrolides were used for 1 year continuously. Do you support that to be a part of the regimen of treatment? And what about the 1 year? Thank you.
So my personal practice in the UK, I think reflects what's generally happening in the UK. But what I am going to say is that practice in the UK is very different from practice in America. So I'm just going to talk about what happens in the UK. In the UK, for reducing exacerbations, first line, we're going to use combination ICS-LABA and long-acting antimuscarinics. That's first line. But there are a proportion of patients whose exacerbations remain troubling or frequent despite that. And then we need to think about additional interventions. And that's when I use macrolide. So if people are already on maximal inhaled therapies and they're still having exacerbations, and those exacerbations are causing real problems, like hospitalization, then I think, yes, there is a role for macrolide, but it's not free. There's a risk of macrolide resistance in the bacteria. You need to make sure that they don't have atypical mycobacteria, because you don't want non-tuberculous mycobacteria to get resistant to macrolide. That would be a disaster. And this story of hearing impairment, perhaps cardiac toxicity, some recent data relating to clarithromycin. So we have to be really, really careful. But the short answer to your question, is there a role? Yes, there is, but further down the line, that's where I would use it.
How long do you use it there at UKD?
Oh, that's a really good question. That's a really good question. So we do have patients who are on it indefinitely. We do have patients who've had a good response and want to have a drug holiday after a period of a year, and then if the exacerbations come back, we restart it. But I don't have a firm view. So I have had patients who've been on it for 3 years now.
All right. Well, we'll have to end with this. Thank you all.
Thank you very much.